Hey everyone, and welcome. Today we're going to dive into something that, let's be honest, can understandably cause a ton of anxiety: your skin biopsy report. Before we jump in, just a quick note that this is an evidence-based general explainer of skin test source material, not individual medical advice, with evidence current as of July 11, 2026. All right, we are going to use this explainer to completely decode that complex paperwork, clear up the confusion, and really help you confidently navigate your next steps. Let's get right into it. So here's our roadmap for today. We'll start by defining the first treatment map. Then we'll read through the main sections, untangle biopsy margins, zoom out to look at the whole clinical picture, discuss exceptions and expert review, and finally, I'll give you 5 specific questions to ask your doctor. Okay, section 1, the first treatment map. What is this report really showing us? Fundamentally, a skin biopsy report does 2 things. It identifies the sample diagnosis, and it records specific features that could change your treatment plan. But, and this is absolutely crucial to remember, it acts as a sample. It is a brilliant first treatment map, sure, but it is not a complete picture of the entire lesion. It provides the evidence to guide the way, but it is definitely not a complete blueprint of every single cell in that tumor. With that foundation in mind, let's move right into section 2, reading the main sections and translating that dense medical terminology. Let's break down this jargon, starting with the big one, the diagnosis. That's simply the name of what was found, benign, precancerous, or malignant. And to even get this diagnosis, the tissue is sliced thinner than a single strand of human hair. Pretty wild, right? Then you might see subtype or grade. This just tells us the microscopic growth pattern or exactly how abnormal those cells look. Depth or thickness shows us how far the process actually extends downward in that specific sample. And ulceration? Well, that refers to true tumor-related loss of the skin surface, which is totally different from just a scrape caused by the biopsy procedure itself. Every single one of these details points your treating team down the correct path. Now, if you see perineural or lymphovascular invasion, that means tumor cells are growing around or within a nerve, a lymphatic channel, or a blood vessel. It doesn't mean cancer has spread throughout your entire nervous system, but it's a specific feature that dictates risk. Margins tell us if the diagnosis actually reaches the examined edge of the physical sample. And please, whatever you do, don't ignore the comments, addenda, or consultation reports. These sections let you know if extra testing is being done or if another pathologist is reviewing your case. They are literally just as vital as that initial diagnosis line. Which brings us nicely to section 3, understanding biopsy margins. This introduces what we call the margin paradox, and it's easily the most misunderstood part of any pathology report. So let's look at this paradox in action. On the left side, you've got a positive edge. This simply means the diagnosed process touches the very edge of the submitted sample. Now, you might think that's bad news, but on a diagnostic biopsy, it's incredibly common. It absolutely does not mean the biopsy failed or was done incorrectly. The next step simply depends on the diagnosis, the intent behind the biopsy, and the clinical context. Now look at the right side, a negative edge. When a diagnostic biopsy says the margins are clear, it is strictly not a clearance test. A negative edge on a diagnostic biopsy cannot be relied upon to prove the cancer is completely gone. Let me give you the hard evidence-based data on exactly why that is. Across 4 studies of 221 diagnostic keratinocyte carcinomas with negative biopsy margins, residual tumor was later found in 55 or 24.9%. I really want to emphasize that. That means almost a quarter of the time, in this pooled analysis, a negative biopsy margin still left behind a residual tumor. This is exactly why a negative margin on a diagnostic biopsy does not guarantee clearance. So why on earth does this happen? Well, it comes down to mixed tumor sampling. You see, biopsies intentionally collect only a part of a lesion just to identify it. But tumors can be heterogeneous, meaning they are mixed. It's kind of like cutting a single square out of a patchwork quilt. That little square might be blue, but it doesn't mean the whole quilt is blue. A biopsy can completely and correctly diagnose a basal cell carcinoma, but unfortunately miss a far more aggressive growth component that's located just a tiny fraction of an inch away. And that perfectly sets up section 4, the whole clinical picture, because context is everything, and the lab report is really only half of the equation. Think about it like this. On the left, we have the microscope. The pathology report provides this fantastic, highly detailed, close-up view of the biology inside that specific sample. But on the right, we have the clinical context. Your dermatologist relies on the exact body site, the clinical appearance of the spot, photographs, and your whole treatment history. That gives them the wider view. The report gives the biological evidence, your doctor provides the context. They're 2 different lenses focused on the exact same problem. Moving into Section 5, Exceptions and Expert Review. Basically, when does your treating team actually need another pair of eyes on that slide? So when does getting another look help? Well, usually when there's ambiguity or uncertainty in the initial report language. It also really helps when there is discordance, meaning what your doctor physically saw on your skin doesn't quite match up with what the report says. It's also crucial for rare tumors. And most importantly, you want an expert review if a new result would literally change your surgery, your staging, or your follow-up care. And I do want to take a moment here to advocate for the entire field of dermapathology expertise. Having a whole specialized field dedicated to evaluating these complex microscopic clues is incredibly valuable for patient safety. But on the flip side, a positive margin doesn't automatically mean you're rushing back for surgery. Here's a great example of an exception. Selected moderately dysplastic nevi with positive margins and no residual pigment may be observed instead of requiring another operation. In this very specific circumstance, an expert clinical exam and whole skin surveillance can safely replace the need for more cutting. Like we said, context is everything. All right, we've covered a lot of ground today. Let's land the plane with Section 6, 5 questions to ask. You'll definitely want to bring these to your next visit. Question 1 is foundational. What is the exact diagnosis? Just ask for it in plain English. Are we dealing with something benign, something precancerous, or is it malignant? Question 2. Which words change risk? Remember those extra terms we broke down earlier? Subtype, depth, nerve involvement? Ask your provider exactly which words in your unique report make this a lower or higher risk situation. Question 3. What do the margins mean for this diagnosis? Keep that margin paradox in mind. Ask whether a positive edge simply means it was just a diagnostic sample, or if it mandates a wider surgical excision based on your specific case. Question 4. Was the sample deep and broad enough? Was this just a partial sample, or was it a true attempt to remove the entire visible lesion? Knowing the intent of the biopsy helps clarify exactly how much weight you should put on those results. And finally, question 5, is there an addendum or reason for expert review? Ultimately, your biopsy is just the very first step on the map. Now that you know how to read that map, are you ready to get in the driver's seat and navigate the wider view with your doctor? Don't let the medical jargon intimidate you. Use it to your advantage. Thanks so much for joining me for this explainer.